Let's talk about ear infections and pregnancy. We'll discuss acute otitis media and acute otitis externa. I am Sandra Goloszewski. I am a nurse midwife. And this is the video I wish somebody had made for me because here's what's going to happen. A pregnant patient walks into your room with an earache, and you'll know exactly what it is. You'll hesitate on what to give her, but by the end of this, you'll know how to diagnose both of these, which drugs are safe, which ones come off the table, and the moment this stops being your problem and becomes an emergency. One sentence holds the whole thing together. The diagnosis doesn't change in pregnancy. The management does. Hold on to that, and everything else is detail. Here are 5 objectives. At the conclusion, you will be able to apply the diagnostic criteria for acute otitis media and acute otitis externa in a pregnant patient. 2, you'll pick first-line and second-line antibiotics using actual pregnancy safety data. 3, you'll know which drugs to avoid and why, not just the list, the reason. 4, you'll recognize the findings that mean she needs to be escalated. 5, you'll counsel her on pain control, breastfeeding, and that early pregnancy risk everybody asks about. So why does this topic even need to exist? Think about your training. OB programs teach you pregnancy. They don't spend time on ear infections. Primary care programs teach you otitis media. They don't spend time on pregnancy pharmacology. Almost nobody teaches the overlap. And then a pregnant patient walks in with 3 days of ear pain. The person standing in front of her is completely capable of making that diagnosis. What happens instead is hesitation. And it's never about the diagnosis. It's about the drug. Read the line at the bottom of this slide. That's the whole video. Diagnostic criteria are unchanged in pregnancy. Management is modified for medication safety. Part 1, diagnosis. 2 conditions, 2 different exams, 2 completely different routes of treatment. Get this step wrong, and the drug you pick never even reaches the infection. Acute otitis media. 3 things have to be there. 1, acute onset, so came on fast. 2, a middle ear fusion, which also needs to be confirmed with either a pneumatic otoscope or a tympanometry. 3, physical evidence of inflammation, such as a bulging red eardrum. And her symptoms are ear pain, hearing loss, or fever. Now, look at the bottom right, because this is the word people skip. Confirmed. A red eardrum by itself is not the diagnosis. You need that effusion confirmed. And if your clinic doesn't own a working pneumatic otoscope, that's the purchasing problem, not a clinical one. Acute otitis externa. Onset is fast, usually within 48 hours. Symptoms are canal symptoms, such as pain, itching, fullness, with or without hearing loss or jaw pain. And the signs are canal inflammation, tragal or pinal tenderness, swelling and redness through the whole canal. Maybe some drainage. Now, the fastest diagnostic tool in your room costs nothing. Tug the ear. Press that little flap in front. If it hurts, that points you to the canal. And tragal tenderness isn't one of the criteria for otitis media. And that one move decides your whole route of treatment. Let's put them side by side. Tragal tenderness is present in externa, not a criterion for media. What you see, such as swollen red canal on one side, bulging drum with an effusion on the other. And then the story, water exposure and itching versus a head cold last week. And then the road that matters most for us is route of treatment. Otitis externa gets drops. Otitis media needs a systemic antibiotic. That's why this diagnosis carries more weight in a pregnant patient than in anybody else. Topical means almost nothing gets absorbed. Systemic means your drug choice is a fetal exposure decision. Same criteria, very different consequences for getting it wrong. Before you treat, run the differential. Otomycosis, which is fungal, think about it when the antibacterial drops didn't work. Contact dermatitis, consider the drops as the cause. Contact sensitization is common with neomycin, and that comes back in part 3. Furunculosis, a discrete boil in the canal, localized, not spread through the whole thing. Chronic suppurative otitis media, ongoing drainage through a perforation, and malignant otitis externa in somebody immunocompromised, that one's an emergency, and we get to it in part 4. All right, knowledge check. Which finding is required to confirm acute otitis media? A, a red tympanic membrane. B, tracheal tenderness. C, a middle ear effusion on pneumatic otoscope. D, ear pain with a recent cold. I want you to pause the video, pick one, and then we'll discuss the answer. The answer is C. The effusion is the piece people skip, and all 3 criteria still have to be there together. Redness alone isn't diagnostic. Tracheal tenderness points you to the canal, and ear pain after a cold fits the picture, but it doesn't confirm it. Part 2, risk and workup. Let's talk about what pregnancy actually changes, what it does not, and what the timing data really says. So, what does pregnancy actually do to the ear? 3 things. Estrogen and progesterone climb. You get circulatory changes and mucosal edema. Pregnancy rhinitis causes eustachian tube dysfunction, and increased susceptibility to viral reactivation may set off or worsen ear complaints. Now, look at the 2 boxes at the bottom because people get this backwards. Pregnant patients don't appear more susceptible to infection overall. What may change is clearance. Immune shifts later in pregnancy may make it harder to clear a pathogen, which can make the disease more severe, so she doesn't appear more likely to get it. She may have a harder time getting rid of it. This is from the Norwegian mother and child cohort. More than 100,000 pregnancies, ear, nose, and throat infections before 17 weeks carried a hazard ratio of 1.27 for spontaneous preterm delivery, confidence interval 1.08 to 1.50. Infections later in pregnancy, no association. Now read the size of that honestly. 1.27 with the bottom of that interval sitting at 1.08. From an observational cohort, that's a real association, and it's a modest one. Here's what justifies treating an early pregnancy ear infection promptly. Here's what it does not justify: turning a healthy pregnancy into a high-risk surveillance. Routine OB follow-up is generally enough. History and exam. On a history, you want to know when did it start? What's coming out of the ear? Any change in her hearing? Has she been in the water? Has she had these before? Does she have a cold right now? Then two that belong specifically to her, gestational age, because it decides the NSET question and have the avoid list. And current medications, because patients self treat ear pain before they even come and see you. Ask it directly, not, are you taking anything? What have you taken for this? Exam, your otoscope, tracheal tenderness, pneumatic otoscope or tympanometry, if you're working up otitis media, mastoid tenderness, cranial nerves, and her neck nodes. And that cranial nerve exam isn't filler. Part 4 shows you exactly what it catches. Labs and imaging. Routine labs aren't required for uncomplicated cases. Don't order a workup just because she's pregnant. Culture the drainage if she's failing treatment or you're worried about a resistant organism. CT is reserved for suspected complications such as mastocytitis or malignant otitis externa with abdominal yielding. And read that bottom line because this is where good intentions hurt people. Don't withhold imaging she needs because she's pregnant. Yield the abdomen, get the study. Knowledge check 2. And I actually realized that I did not put another slide in here. So the answer is already there. But so the patient has acute otitis media at 12 weeks. What does the timing data support? A, no association exists, no change in care. B, treat promptly, continue routine OB care. C, start serial cervical length surveillance. D, refer to maternal fetal medicine. Okay, so the answer is B, treat promptly and continue routine OB care. The association is real and it's modest. It changes your urgency. It doesn't change her risk pathway. So telling her nothing is known would be wrong. And escalating her to high risk surveillance over hazard ratio of 1.27 medicalizes a completely normal pregnancy. All right, part 3, treatment, 2 decisions, and people reliably get one right and one wrong. Pain control first, then the antibiotic. Okay. So analgesia first, because the pain is what brought her in, right? So Tylenol, first line all the way through pregnancy. It is preferred in all 3 trimesters, and it's fine with breastfeeding. Now, NSAIDs, consider them only in the 2nd trimester and after 20 weeks. They're out due to oligohydramnios and premature closure of the ductus arteriosus. The 20-week line is the thing everybody knows and few people apply. Here's what I see. Here's the pattern that I see. The antibiotic is right and the analgesic is wrong because pain control gets treated like an afterthought. And here's the practical piece. Ask her what she already took. Ear pain comes on fast and hard. She was already in her medicine cabinet before she even picked up that phone. And Motrin is what's in there. Everyone has it. Then tell her why. A patient who understands the ductus arteriosus doesn't restart the Motrin on day 3 when the Tylenol isn't quite cutting it. Otitis media, picking the antibiotic. First line is amoxicillin, standard dose. Beta-lactams are what we lean on in pregnancy. They're considered safe. Your second line splits 2 ways. If she failed first line therapy at 48 to 72 hours, go to amoxicillin clavulanate. If she has a penicillin allergy, go to a cephalosporin. Those are safe alternatives as long as there's nothing severe in her allergy history. And of course, say this part out loud to yourself. Amoxicillin clavulanate is not your penicillin allergy answer. It is a penicillin. One question on the clavulanate: high dose of it, such as above 600 milligrams a day, has been associated with necrotizing enterocolitis in preterm neonates. That matters most, actually, near delivery. Now, azithromycin, this is the one people get wrong, and for a defensible reason. Its safety data looks fine, placental transfer under 10%, it loses on efficacy, not safety. Its H influenza coverage is weak. That's the whole reason it isn't first line. And the number at the bottom, 48 to 72 hours, that's your decision point, not a week. All right, here's the avoid list. Learn the reason, not just the name, because the reason tells you when the restriction applies. So, tetracyclines contraindicated after the fifth week due to dental staining and skeletal effects. Trimethoprim sulfa, so your Bactrim, out in the first trimester for teratogenicity and out near term for neonatal jaundice and kernicterus. Your systemic fluoroquinolones, reserve them for when there's no alternative. The concern is cartilage toxicity. And notice that word, systemic. So topical fluoroquinolone drops are a completely different conversation. And that's the next slide. Systemic aminoglycosides, life-threatening infections only, fetal ototoxicity and nephrotoxicity. And if you do use them, drug levels and renal function monitoring are essential. Otitis externa. Topical is preferred, and the reason is exactly why this diagnosis matters in pregnancy. Systemic absorption is minimal. Use fluoroquinolone otic drops, Cipro with Dexa, or Oflaxin. Fetal risk is expected to be minimal, and they are preferred over anything with an aminoglycoside in it. Acetic acid 2% is a non-antibiotic option for mild cases. Now, here's what to avoid. Neomycin and polymyxin B when you can. Ototoxicity risk if that eardrum is perforated. And a lot of people get contact sensitization from neomycin. Here's the practical trap. If the canal is swollen shut, you can't seal the eardrum, so you don't know whether it's intact or not. And that uncertainty is what takes neomycin off the table. 2 adjuncts. Put a wick in when the canal's swollen, so the drops actually get down there. And drops that don't reach the infection aren't treating it. And safe systemic antibiotics for when it spreads past the canal, like cellulitis and fever. All right, knowledge check number 3. So, otitis externa at 29 weeks, and the canal is too swollen for you to see the eardrum. A. Neomycin polymyxin B and hydrocortisone. B. Ofloxacin with a wick for the swelling. C. Oral amoxicillin alone. Or D. Oral ciprofloxacin. Go ahead and pause, think about it, and then come back. So the answer is B. ofloxacin otic solution with an earwig for the canal edema. So an eardrum you can't verify rules out neomycin because of the ototoxicity risk with the perforation. And systemic therapy, whether that's amoxicillin or Cipro, isn't indicated until it spreads past the canal. Plus, systemic fluoroquinolones are reserved for when there's nothing else. Part 4, when to escalate. The hardest skill in outpatient practice is knowing when the case stops being yours. Here's what decides it. All right, here are 5 red flags. 1. Malignant otitis externa, high fever, granulation or necrotic tissue in the canal, cranial nerve involvement. That's an emergency. Hospital, IV antibiotics, and debridement. 2. Mastocytitis, swelling and tenderness behind the ear with the pinna pushed forward. CT and IV antibiotics. 3. Intracranial, fever that won't quit. Severe headache, altered mental status, focal deficits. Think epidural abscess, like meningitis, sigmoid sinus thrombosis. 4. Facial nerve palsy, which can happen with herpes zoster oticus, Ramsay Hunt, and acyclovir is considered relatively safe in pregnancy, so look at the outside of the ear before you write anything down. A vesicular rash changes the diagnosis and it changes the treatment. That's why your cranial nerve exam matters. 5. She's not better at 48 to 72 hours on appropriate therapy. Monitoring and delivery. Reassess at 48 to 72 hours if she isn't improving. Check her hearing if she's got persistent loss or you're worried about sensorial involvement. For OB monitoring, routine follow-up is generally enough, including before 17 weeks. On the delivery side, an uncomplicated ear infection doesn't usually change delivery planning. If she's on systemic antibiotics near delivery, think about the neonatal implication. That's where the clavulinate concerns stop being theoretical, right? And here's one you won't see coming. So bad vertigo from labyrinthitis or Meniere's. It can affect how you position her in labor. Meclizine and dimenhydrinate are considered safe. And underneath all of it, treat the active infection before delivery. So she isn't dealing with it postpartum on top of everything else. Postpartum and breastfeeding. So amoxicillin, cephalosporins, and Tylenol are all compatible with breastfeeding. NSAIDs come back after delivery so that 20-week restriction ends when the pregnancy has ended. One nuance on Cipro, systemically, it is excreted in breast milk. Topically in the ear, systemic levels are negligible. Same drug, different route, different answer. For hearing follow-up, if the hearing loss sticks around after the infection resolves, get otometry. And pregnancy-related hearing changes, including otosclerosis getting worse, may warrant an ear, nose, and throat referral. For recurrent infections, look for eustachian tube dysfunction, allergic rhinitis, or something anatomic. And remember, pregnancy rhinitis usually clears within 2 weeks of pregnancy. 2 weeks of postpartum. Now, let me be honest about the evidence. Evidence for managing ear infections specifically in pregnancy, is limited. We have case reports, retrospective studies, expert reviews. There are no randomized controlled trials. And the drug safety data come from observational studies, animal reproduction studies, and pharmacokinetics. That's true of most pregnancy pharmacology, anyways, and it's exactly why the reasoning behind a restriction matters as much as the restriction itself. The strongest piece of epidemiology here is that Norwegian cohort. The FDA labeling supports the minimal absorption argument for the otic drops, and the diagnostic frameworks come from the American Family Physician Reviews and the AAP guideline. The gaps: no trials in pregnancy, and long-term neonatal outcomes after aminoglycosides exposure in utero are still understudied. Here are 6 things to take with you. 1, the diagnostic criteria don't change in pregnancy. Management does. 2, pull the ear. Tracheal tenderness points to the canal, and canal disease is treated topically. 3, acetaminophen first, NSAIDs out after 20 weeks. 4, amoxicillin is first line, cephalosporins for a non-severe penicillin allergy. 5, these are off the table, tetracyclines, Bactrim, systemic fluoroquinolones, systemic aminoglycosides, and 6, 48 to 72 hours is your decision point. And granulation tissue with a cranial nerve sign is an emergency, not a clinical problem. All right, one thing before you go. There is a 1-page job aid in the description on safe, cautious, and avoidance of medications in pregnancy. So it is one printable page. Put it wherever you prescribe. Keep it on your phone.